Good morning, the Monday after Thanksgiving. Thanks all for being here. I'm going to be talking about selective mutism today and hopefully help you feel a little bit more confident and comfortable in working with this population. We're going to be talking about identification, interaction of kids and families with selective mutism, and treatment consideration for medical professionals. The objectives today are to describe what SM is. It is an anxiety-based communication disorder. It's also considered a hidden disability. If you ever see somebody wearing a sunflower lanyard or have any marking like a card with sunflower on it, that is a designation for a hidden disability, which a lot of mental health conditions are hidden disabilities, and SM is one of those. We're going to talk about the prevalence, co-occurring conditions, and myths that are associated with selective mutism. I hope to inform you about some best practices for interacting with patients and families in your care and help you learn some evaluative tools to understand how to best help your family if you do suspect selective mutism, and giving you some information and some tidbits on explaining treatment to your families and making appropriate referrals. So first, I just want to say thank you so much for being here. There is a need for providers and professionals to understand selective mutism. Only 36% of children with SM receive the help that they need and the care that they need. And part of that is because there are so few credentialed or knowledgeable professionals in the field. If you look at the selectivemutism.org website, which is also known as SMA for the Selective Mutism Association, you will see 3 psychologists in Arizona that provide treatment in person and 15 virtual. IPACT initiative, which is allows licensed psychologists to apply for a credential where they can practice psychology across state lines. There are 15 listed there, but as you can see, 12 of those would not be in the state. And on average, it takes 4 years to receive an appropriate diagnosis. And part of that has to do with the limited number of professionals in the field, and also the lack of knowledge and awareness. So hoping to increase that awareness today. Selective mutism is an anxiety-based communication disorder where a person is unable to speak in some settings and to some people because of anxiety.
AZ Blue has health plans that make sense. $0 per month premium health plan with $0 or low-cost generic drugs and 24/7.
Also called a health condition very few of us understand. Also called SM, is a complex anxiety disorder characterized by a person's inability to speak in certain situations like school, work, or other group settings. But they're able to communicate comfortably at home or with family. And that silence, without any explanation, leads to confusion and frustration. From the outside, selective mutism may seem a lot like shy or rude behavior, but no one with SM chooses not to talk. Internally, they're dealing with feelings of anxiety and panic that create a genuine fear of speaking. Selective mutism typically appears in early childhood, affecting about 1 in 140 school-aged kids. But people of any age can be living with SM. How it manifests and its daily impact on life is different for each individual. SM's most common symptom is impaired speech in those certain high-anxiety settings and situations. People living with the disorder report that their fear often leaves them completely frozen. Other signs and symptoms include relying mostly on nonverbal communication and struggling with eye contact when they're anxious. And some folks avoid public interactions entirely. But SM can be overcome. If you think you or a loved one may have selective mutism, a professional diagnosis is a great first step to finding treatment. There are plenty of research-based treatment options available, including behavioral therapy, cognitive behavioral therapy, speech-language therapy, and various medications. For friends, family, teachers, and peers, simply taking the time to understand SM is essential to offering real support. Initially, simple things like a kind welcome, extra warm-up time, and lowering expectations for communication can make a big difference. Then, with time and acceptance, you can take the small but critical steps toward verbal communication together. And the Selective Mutism Association is committed to providing you with further information, tools, and resources through our website. Because with care, patience, and understanding, we can help people with selective mutism find their voice.
We're going to get rid of this in just a minute.
We're going to talk about beyond talking, targeted exposures for the bathroom and eating.
Oh, sorry, guys. I was saying this morning that the technology piece is my least favorite, so I do apologize for that. Okay, I think we're back on track here. Okay. So, in the ICD-10, elective mutism sometimes is still known as that, although the new term is selective mutism. So if you do see elective mutism, it's talking about the same thing. However, the appropriate term at this time is selective mutism. In talking about some facts about SM, it presents itself at about 0.7% of the K2 population. That's kindergarten to second grade. And that would be about 31,500 kids in Maricopa. So just to give a sense of how many that is. It sounds rare, 0.7%, but when we think about the number of kids that need to be served and the amount of professionals that are trained in this area, they can, they're really mostly led to the professionals who are trained, which does create some backlog. Kids are usually diagnosed between ages 3 and 7. That's typically because that's when they're entering preschool or entering kindergarten. And that is when teachers are noticing that, hey, this kiddo isn't really speaking much. Typically, the first line is teachers mentioning it to parents, asking parents, is Johnny or Susie talking at home? And a lot of parents are surprised to hear that their kiddos are not talking at school because they're comfortable in their home environment. They're talking in their home environment with their family. And when they get to school, they're not. We know that SM can impact any demographic. There does tend to be a female to male ratio where females tend to present more so. When we think about selective mutism, some of the questions that come up or some of the wording that's used has to do with shyness. And so I wanted to show this slide really just to show the difference between what shy is and the number of kids that are typically affected by shyness. There are, 15 to 20% of babies are considered inhibited, and 40% considered, outgoing. So we're starting, at infancy with this 15 to 20% with this shy kind of temperament. However, when we look at SM and we look at the difference between kids who are shy and are silent versus kids who have selective mutism and are silent, in shy kids or with a shy temperament, it's temporary. Usually they take a little bit of warm-up time, maybe 5, 10, maybe 15 minutes, and then they're able to talk freely, speak with their peers, speak with adults, but it could take a little bit of warm-up time. Whereas kids with SM, the silence is persistent. So even after a warm-up time, they're still not talking to other people. This can go on for years. It can go on across environments. Kids who are shy, they might not talk after a stressful day or a stressful experience. They might not talk during small talk, with adults. No kid really likes to have small talk with adults. So even shy kids have a harder time with that. And with SM kids, anytime a non-family member is present, so if they're in your office, they're at the dentist, they're at the doctor, they're in a school, new environment, they're talking, they're expected to speak with somebody new, they're not speaking. These are also kids with SM, they're not talking on the playground. They're not talking during lunchtime. They're not asking for help. They're not going to the nurse when they get hurt, so it can be really concerning. So I want to look really at the specific definition because I think there's a lot of clarity that can come from that. So we're looking at duration of silence of at least 1 month, not limited to the first month of school. So what that really means is when a kiddo is starting a brand new school, like preschool, or maybe they've never been in school before and they're starting kindergarten, we have to allow for an adjustment period of at least the first month to go by. Now, there could be a kiddo who maybe the first month, they're not speaking in preschool. Then they go to kindergarten. They maybe aren't speaking quite a bit at all in preschool. They go to kindergarten. Now we're on our second year. We're not going to wait another month into kindergarten. We know, hey, they struggled in preschool. They weren't talking to any of their teachers. They weren't talking to any of their peers. But this is when they're starting in a new environment in that first month of school. Failure to speak is not attributed to lack of knowledge or comfort with spoken language that's required in social situations. So obviously a kiddo who doesn't know the language very well, or maybe has some other kinds of condition going on, which we'll talk about some comorbid conditions in a moment, but it cannot be fully attributed to anything else related to lack of knowledge of language. So that is important to assess that, because it cannot also be explained exclusively by a communication disorder or not exclusively during autism. Now, this becomes kind of an area of discussion in the field because it can co-occur with autism, but the language impairment from autism cannot be specifically just selective mutism, right? Because with the diagnosis of autism, we have a language impairment that's central to that diagnosis. And there's more than just being silent that comes with that articulation concern or social language and understanding difficulties. And looking at some comorbid conditions, other anxiety disorders, very prevalent with SM, social anxiety, it depends on what study you look at, but a very high comorbidity, 76 to 90%. Separation anxiety is also high amongst kiddos with SM, about 31%. If you think about why they might be fearful to separate, if the only person they're comfortable talking to is their family or their parent, being away from that safety person can be really challenging. When we do treatment, we do address the separation first, and then we can work on the SM. And general anxiety, 28%. Language impairment. So this is important to note that SM, right, is not a language impairment, it's an anxiety disorder. However, we found that in research that 40 to 60% of people with selective mutism also have some type of language impairment. Again, really important to figure out how to assess for that through some home observation or rating scales, getting the kiddo comfortable first, and then doing the language evaluation. But it is looking at articulation, so the ability to form words, and also in some expressive communication delays. And then we have a high co-occurring comorbidity with sensory processing impairments. And this is not unusual as it relates to other anxiety disorders as well. A lot of anxiety disorders do have sensory processing, impairment components to them. But this was a study that looked specifically at SM, and there was an 88% comorbidity there. Autism spectrum disorder. This is the most recent study. Previous studies had shown like 7%, 10%. As we know with research, it all has to do with your sample. And so, that is where some of the difference comes in. So I would say really 7 to 63%, which is not really great. There definitely needs to be a lot more research in that area. But I think it's important to know that it can coexist. So what does SM look like? These are kids that speak at full volume when they're with their parents and alone. When I'm doing treatment, I usually ask families to provide a video to me, show me what your kiddo is like talking at home. I want to know what their typical language is like. That's another way that I kind of backdoor assess for social language or language, but looking at, are they speaking a full volume at home with their parents in a comfortable situation, but they struggle to speak to peers, teachers, doctors, even if they want to. So they have a desire to. This is not a behavioral issue. It's an anxiety issue. They may speak by whispering in social settings. You might notice that the kiddo is turning to their parent when you ask them a question. They might be whispering to their parent. They might just look at you like deer in headlights, like they're frozen. They might not ever speak in school or in unfamiliar environments. They're unable maybe to ask for a bathroom break or to speak up if they're in pain. They're also sometimes not engaging even in movement activities. In preschool and kindergarten, there's those large movement, gross motor activities where they're moving their bodies to songs and engaging, with other kids, and everyone's doing the same movements. And these are kids that are just standing there, not moving. They might gesture or write. You might see them texting instead of verbally communicating, and just choosing easier ways for them other than using their voice. I want to do a little myth busting here and I could do a whole hour on this one, but just quickly, I think it's so important to know as providers what SM is not. So it's not a behavior, it's not defiance, it's not a kiddo being difficult. Unfortunately, we see these kids in the principal's office with write-ups, with expulsions, with suspensions, because they're not answering their teacher. Because the teachers ask them a direct question and they're not responding. So we need to be very cautious and careful that we're not labeling this as the behavior or as defiant. It is not hard to treat. There are very effective treatments for selective mutism. It's just about finding the right clinician to do the right work. It is not caused by trauma, and I think that's a long-standing myth. Hopefully, we're past that now, but just to know, right, we can have a silent period that follows trauma, but SM is a developmental disorder that's an anxiety disorder that we see when kids are developing language. So it is not caused by trauma. When we do have trauma and selective mutism that follows trauma, we have to treat the trauma first. So if you have a case or a kiddo that has experienced trauma, they were talking fine, they were talking to teachers, they were talking to peers, everything before the trauma. Now, is somebody who is trained in SM probably the best person to work with a person who has trauma and SM? Yes, because this person is probably not going to talk to another clinician unless they understand, how to handle the SM as well. But the trauma does need to be dealt with first. It's really not something that's okay to ignore. We know that some people do, I'm going to put quotes around, grow out of SM. However, usually they are left with some type of anxiety disorder. It can kind of shift into, social anxiety will still remain, generalized anxiety will still remain. And the thing is, we really don't know what happens. We don't have enough data or research on what happens to kids that we don't treat versus what happens to kids that we do treat. And we know that treatment works. So we want to get kids into treatment because we know it works. We don't want to take the stance that, just wait it out, it'll get better. That's really not the message we want to be giving families. When you have a kiddo who presents as mute in all settings, this is a flag that this might be something to consider related to trauma or PTSD. It's not selective mutism if they're mute in all settings. We may be looking at a developmental disorder. We may be looking at developmental delay. We may be looking at exclusively autism or something like that. SM is specific to individuals who speak freely and comfortably in at least one environment, and typically the environment is at home or with friends and family. If you're not sure or you have a kiddo with mutism across all settings, it's really important just to reach out and get some consultation for appropriateness of a referral. All right, this is the part that I hope you guys are super excited about today. How can you be most helpful to your families or to your patient that shows up and you suspect maybe SM? So the first thing that's going to be super important is establishing that rapport, right? So be a good listener to the family. If they're telling you, hey, this kiddo, my kiddo doesn't talk. They don't talk in this environment. They don't talk in that environment. Don't expect your environment to be different. Even if you're the kindest, sweetest person in the world, they have an anxiety disorder. It may go a long way to be sweet and kind and positive with them, but lowering expectations is going to be your best bet at the moment. We have that sticky note in the child's file on our EHR system. Try to learn something about them. When I take notes about my kiddos that I work with, I always put something in that little sticky note, that yellow sticky note, just to help people, because I know if my kiddos ever end up in the ER, they end up, at the hospital in some other way, I want the provider to know, that they have a dog named Elmo, or that they really love to draw, or their favorite band is, or their favorite, Taylor Swift or something like that. So find something that you can relate to them about, maybe bring in something, show them a picture of something, engage with them in some way, something related to their interests. That's going to help them feel more comfortable, and providing a warm and safe environment, which we'll talk about what that looks like in a moment, and really avoiding eye contact with the kiddo, because it's such a direct nonverbal request to request someone to look at you or to look directly at them. And these kiddos with anxiety, they don't like people really looking at them. So, just kind of avoiding eye contact, doing something else as you're talking to them. I know it might be out of the norm of what we're used to, but that can be helpful. Creating a safe place with no or low demand on language. So first, ask the family their preference for how you can receive information from the patient. And that might look like many different things, right? That might include asking a question and then literally stepping out of the room for your patient to answer their parent, and then the parent to get back to you, right? If the kiddo is uncomfortable speaking in front of you, this might be the best way to get information. You want to give them lots of space and time to respond. So even when requesting a nonverbal response, you might ask them to write something down. You might ask them to give you a thumbs up or thumbs down. On a scale of 0 to 10, how uncomfortable do they feel? Can they show you with their fingers, right? So asking for a nonverbal response, but giving them lots of processing time, 5-10 seconds before going on, before deciding that they're not going to answer you, giving them that time, because when they're anxious, right, the thinking part of their brain isn't working super well, the anxiety is taking over, so they need some extra processing time. And then you can help develop signals with them, right? Maybe they're writing, maybe they're gesturing, maybe they're talking to their parent, that thumbs up or thumbs down. And really important, especially if they're in your care, over multiple days, or you're going to be seeing them more than once, give them a way to express to you. And maybe the family already has this, that's why it's important to talk to them, but how are they going to express to you, if they're in pain, or if there are safety concerns, or if they need to use the restroom, right? Or if they're hungry. Or if they're thirsty. So giving them some way, a lot of times we'll use like pictures, and the kiddos can point to the pictures, or you're giving them enough time with their parents, with somebody else not in the room, that they can feel like they can communicate comfortably. Generally, at first, when you first meet a kiddo that you think, this kiddo's kind of quiet, they're not really talking to me, you want to avoid those questions and expectations at first. So even as simple as a greeting, right? When we say, hi, how are you? Which is a typical way to greet somebody, that is a question to them, and that is anxiety provoking. And so even just saying hi has a social demand to say hi back. So I suggest something simple like, it's really good to see you today, or I'm so glad you're here. Something that does not require any kind of response is just a general, good way to greet somebody who you might suspect has anxiety. You want to avoid giving any demand right away if you can directly to the child. You might pose it as, I was wondering if you would consider, doing this, or you can speak directly to the child, but giving them a way to respond to their parent would be really good. And then avoiding any real negative criticism, even if you're joking, it can be taken, especially their anxiety is really heightened and they're maybe not in a space mentally where they can kind of take jokes like sarcasm or things like that. So you want to avoid that. And then inviting the parent into the conversation, right? Like how does Johnny usually respond, when doctors ask a question, or just including their feedback into that can help them feel more comfortable as well. When we think about the questions, we're used to asking a lot of questions to our patients and to our clients. And so I wanted to highlight the 3 types of questions and the demand load that happens in the brain based on these types of questions, so that when a kiddo is anxious, their anxiety part is taking over, the thinking part isn't working so well, what kinds of questions are going to be the easiest for them to answer. So a yes, no question is going to be least demanding. It gives the option for nonverbal responding, that thumbs up, thumbs down, giving them, the option to nod their head or shake their head. Now, I will say in therapy, we avoid those, but when they're in your office and you're really just needing to get responses from them, it's okay to use those yes, no questions. And I gave an example here of what is a yes, no question. And the next level up is a forced choice question. So that's giving a little bit of demand on the thinking center part of the brain, but it gives the patient the choices to choose from. So for example, you might say, as it relates to your broken arm, did you fall? Did someone hurt you? Or something else? Giving them that something else option is really important, although I will say that kids with SM, if it is something else, they're not going to necessarily tell you that's what that something else is. They will literally say to you, repeat back to you something else. And again, that's just because the anxiety part of their brain is taking over. So you may be doing a little bit of a guessing game, but just to know that is a next level question. And then the hardest question for them to answer are going to be open-ended questions, those who, what, where, when, why, how questions. So, how did you hurt yourself is going to be the hardest kind of question for them to answer. So keeping that in mind, and also keeping in mind the ability for them to do those writing or different gestures. The types of questions that you can transition from yes, no questions to forced choice questions to open-ended questions. And there's some examples here. So just thinking about, okay, I really wanted to ask them this question. It's an open-ended question. How do I change this to a forced choice question? Or how I change this to a yes, no, low demand question. This is an illustration that really shows the difference between types of communication. We don't go necessarily from not talking to talking. And so I think it's important to look at these levels of communication. Level 0 is no communication. This is when they're frozen, deer in headlights. It looks like they might be ignoring you. They're not responding at all. Then you know this child is at a 0 for communication. A 1 is nonverbal. So this is where they might be giving those gestures, thumbs up, thumbs down. They might be pointing. They could be writing answers. So maybe you're asking them questions and they're able to write to them. That would be a level 1. And handover takeover is really, I'm going to hand the child something. They're going to take it from me. And I'm going to maybe ask them to hand me something. Okay, if they're able to engage in that, that is a form of communication. And so you know that, okay, they're at a level 1. Level 2 is where they're using their parent as an intermediary. Some of the kids I work with tend to use peers as intermediaries, but it's really where a question is asked to the child responds to the parent responds to you. And so, there is a little bit, sometimes parents say, well, I try to tell them not to do that. And I say, well, it's really important that we get there because we need to get there before the child's going to be completely verbal. So it is an okay step. And we want to honor that if that's where the child is in the moment, knowing that they're going towards that verbal responding. Initiation, when we talk about being verbal in any of these, actually there's initiation and responding. They might do really well responding, maybe even verbally, but initiating might be really challenging. So kind of keep that in mind as well. When a child with SM talks, one of the things that keeps them sometimes from talking is this fear or reaction of, oh my gosh, I haven't talked this whole time I've known this person. How are they going to react to me? How are they going to respond? Are they going to be so excited and they're going to make a big deal about it? And so we don't want to do that. We want to do simple and casual praise. If they're responding to you, or they're talking to you, even if they're giving you a nonverbal, you're going to just say, thanks for letting me know. It's a very simple, casual praise. It's specific praise, which is not, oh, you're a good boy or you're a good girl, which would be more general, but specific to what they did. Thank you for letting me know that. Thank you for writing that down for me. Thank you for giving me a thumbs up, whatever it is that they're doing, just giving them simple and casual praise. Okay, so how can you assess for SM, right? How can you know what are the tools that are out there to help you with this? There are some tools that are readily available. The Selective Mutism questionnaire, there's a school speech questionnaire, and then there's the FSSM, which really just asks a lot of different questions. There's another one called the Express questionnaire, asks questions about how the child communicates in multiple environments, keeping in mind if the child has difficulty communicating in the home environment, we're probably looking at something other than SM. And also if they have a different primary language at home other than English, there is that expected silent period in new environments. They can be helped. We can help educate parents to understand about that. But we want to make sure that we're respecting, that they're learning a second language and as English as a second language. So we want to ask, when you're in the community, when you're at community events, where other people are there speaking your home language, is your child also silent in those situations, or are they talking freely, in their home language? So those are important things to understand and assess for. If you continue to have concerns about selective mutism, you're like, yeah, this is textbook. They are not talking at school. They are, only talking to teachers, not to peers, or the other way around. And the family wants help, and you are connected to PCH in any way, you can send a referral to psychology. There's a friendly name in there, selective mutism. Go ahead and send them over. I'm the one looking at that. I'm happy to help. You can also share resources with parents. I feel this is super important to resource our parents. SelectiveMutism.org is a really great website. It has a ton of resources for parents, for educators, for professionals, lots of videos, lots of things to resource your parents with on that website. If a kiddo needs a procedure, maybe they need a surgery, or they're going to be coming back multiple times and spending many days at the hospital, there are some additional things that you could do to help your patients feel more comfortable. You can start working on some nonverbal responding with them, that handover takeover, handing them things, having them hand them back to you. See if they'll do that. Again, that would be moving from level 0, right, to level 1 on that communication bridge. If possible, you can allow parents with the patient to come to the hospital, be able to spend time in the room where the procedure is going to happen. Can they meet the nurses ahead of time? Can they meet the anesthesiologist ahead of time? Can they be walked through the procedure? What does it look like? And I know we have, child life specialists here. I had one work through a procedure that a kiddo was going to have. One of my clients, they are fabulous. They will walk through with pictures. They will explain everything that's going to happen. Very important for kiddos with anxiety to understand what is going to happen, to know what they can expect. If it is possible, I know it's not always possible, but if it is, to provide, the same room, the same nurses, the same providers as much as possible, so that kiddos can get comfortable and they're not constantly being introduced to new people that they have to communicate with. And actually, the last thing I'll say on that one is, if they are needing to be introduced to new people all the time, if there's one person that could be steady, so one person that could help introduce each new person to them, that can also be helpful. When we look at treatment, the gold standards for treatment, and I think this is important to understand, because parents might ask, well, what are we going to do? There's nothing we can do, right? There's a lot we can do. So cognitive behavioral therapy is a gold standard. Exposure situations with a clinician who's trained in understanding what those ladders might look like for exposure. A lot of parent education, and we know medication is extremely effective in treating anxiety disorders. As a psychologist, my treatment goals for any kiddo really with anxiety is not to get rid of anxiety, but to understand and to be able to tolerate the uncomfortable, right? To have it be something that is not impacting their daily life anymore, giving them some tools to manage anxiety. And overall with SM, increasing the people, the settings, and the environments that they are responsive and providing spontaneous speech, right? Where they're just speaking without being prompted or asked a question, which would be like initiation or just sharing information. When we get a kiddo with SM, there's an intake, an assessment, there's structured observation protocols. I look at how does the parent interact with the child. A lot of the treatment for SM, is called parent-child interaction therapy for SM, especially our younger kids. And so there's a lot of work on how is the parent responding to the child, what kind of praise are they giving them. There's all sorts of skills and things like that goes into that. We're giving, a lot of psychoeducation. I'm doing a lot of psychoeducation. I will do psychoeducation for teachers, parents, and the client. Obviously, depending on the age of the client as well, the education is gonna look a little bit different. Typically, it's recommended to have individual weekly sessions, and mostly, obviously, that's based on the research that shows that's how the research has been done with the treatment. And helping parents create real-world goals, and also helping teachers with that as well. There are some treatment protocols or things in place available, social skills group, and intensive camps that are also available throughout the country for kids with SM. So those are also options available to your families. When we look at treatment varying by age, the younger kids, parents and clinicians are setting up the environment to help them be successful. We're training the people that are interacting with them. We're doing a lot of exposures when the kids are younger. The exposures are easier to do and usually more easily tolerated. As kids get a little bit older, we think about, they've been silent maybe in school, since the time they were 2 or 3 or 4. Now they're, 12, 13. It gets a little bit more difficult. We definitely include them more in their treatment. They can start to understand things more from a cognitive processing perspective. And then as kids are older and even into adults, they become responsible for utilizing their own anxiety reduction coping strategies. And most of the work is done directly by the client. Typically, initial treatment looks at, is about 8 to 12 weeks. We really want to see improvement within about 6 to 10 hours of direct therapy. So sometimes that's, 6 sessions to 10 sessions. Doing some exposure therapy, some PCITSM, school support, providing some community challenges. It used to be, I think it still is, if you go to Walmart, you can get a free cookie, but you have to ask for it from the bakery. So that would be a really popular exposure for us to do, to give to our families to do. And they would start with, first ask mom, use mom as an intermediary, or dad to ask for you, and then start asking, one word at a time, and kind of building that up and shaping that. We do a lot of rewarding for communication, especially with our younger kids. They get, really excited about sticker charts and things like that. So we want to combine what's happening at school, at home, in the community, and have the kiddos, sometimes they'll work on brave books or put together some brave things that they've done, and they could draw pictures of it, they could take pictures of it, and they could kind of go back through it and see, these are the things that I've done to help them feel more comfortable and confident in their skills that they're learning. We do know from CAMS, which you may be familiar with, the child adolescent multimodal study that really looked at outcomes related specifically to social anxiety. There isn't, a whole lot specific to SM as far as research goes. It's building. But we know that in looking at therapy alone, medication alone, they are effective, but most effective when combined. And the effectiveness of combined therapies and therapies alone, there was a 6-month follow-up that was done by PSN2Me in 2013 that looked at the 6-month follow-up after this original CAMS study and saw that the effects remained. So we know that using both together in anxiety is the best. There's always this question as to who is going to be the best candidate for medication. We do know, this is just another slide that shows, SSRIs being, very effective and lowered inhibition to create opportunity for practicing skills. And when we look at the best candidates for medication, there is that question of, do we wait until they're older? Do we try therapy first? And, there's pros and cons to both, right? So waiting, if a family is not on board with medication, then yes, obviously therapy can be tried first. We can have a lot of great success with therapy. Usually, again, 6 to 10 sessions in, if they're not making progress, I'm recommending a referral, to someone who can do medication management. We don't do that in psychology. I have had clients show up, in my office saying they're here because they want medication. So hopefully everybody understands that here. But the benefit to medicating kiddos younger is that they are able to practice skills with some lowered inhibition and be successful with it, and then build upon those. And, as any prescriber out there might know, it doesn't have to be lifelong. It doesn't have to be long term. So explaining that to parents can be really helpful too. We know that family history, parents is a huge genetic component with selective mutism, social anxiety, any kind of anxiety, right? Many times in my office, parents will say, well, I didn't really talk either in school, or I've always been, uncomfortable in social situations. Okay, bingo, bango, right? Well, I started anxiety medication, 5 years ago, and it's been really helpful to me. Okay, great. Well, what are you taking? Because there tends to be a good genetic component to, whatever parents are taking. If it's helpful for them, then it can be helpful for the child typically. If they have comorbid conditions, extreme social anxiety, OCD, autism spectrum, other behaviors, things like that, then we want to maybe be looking more heavily at medication. And again, this last one, unsuccessful behavioral therapy, I'm going to start referring if they're not doing well or responding well to therapy. This slide is from Dr. Rupal Upadhyay. She did a presentation with the SMA conference that I was at recently. So all of you that are prescribers probably understand this slide a little bit better than me, but I did want to include it because I think it could be helpful to somebody who does prescribing. I think what I got out of this was understanding that with younger kids, doing a 12-month plan and also recommending monthly visits was helpful just to see how they're doing. When we look at resources, and I spoke earlier about resourcing our families, but there is the Selective Mutism Learning University that is also a phenomenal resource for families. It is free for them. It teaches them all about selective mutism. They can learn about how to interact with their child. They can learn about how to provide information to the school and how to be an advocate for their child. That Selective Mutism Learning University and Selective Mutism Association, those two at the top-notch favorite ones. If you guys send your clients there you have concerns about and they end up in my office and they've already taken all the classes, they're going to be way ahead of anybody else that's just showing up. So if you can provide that resource to them, that would be fabulous. There is a podcast if you're interested in learning more, or if you have a parent that might be. It's called SM Out Loud. It's done by somebody who had selective mutism themselves. And is them, I think it's them and their mother that puts this podcast together. The Child Mind Institute also has some really great resources on selective mutism. There are social media. I guess Facebook is kind of, I learned from my kids, this is very outdated. Instagram or whatever the new one is. But there are state-specific selective mutism support groups, parent support groups that are nationwide, that are international, that parents can link in with other parents. They can also get information about those groups on the Selective Mutism Association website. So if you're thinking, gosh, this is a lot, what do I give them? Selective Mutism Association website and Selective Mutism Learning University, it would be amazing. And then there are some apps that we tend to use in session. Even just giving them meditation apps. So Headspace is a really great one. You might already have some that you're providing to your families. Meditation, yoga, anything that they can do to help, lower their anxiety is going to be helpful with this. And then the last ones there with the funny names, those are some of the ones we use that are voice activated apps that we use in session to help encourage speech with our kiddos. I wanted to also just show this slide and kind of go over some of these if you're interested. So this Overcoming Selective Mutism, the Parent's Field Guide, is a great resource for parents. It's a great resource for clinicians or providers or anybody that just wants to learn more about selective mutism. I think it's a fabulous book. Learning to Play the Game is a book by Jonathan Kohlmeyer, who is an individual who had selective mutism, went through school. And in this book, he wrote this book, I believe, when he was leaving for college or after his first year of college. And it was all about his experiences in school and with doctors and people that he would encounter and the positive experiences he had and the ones that were not so positive. And so I encourage providers as well as teenagers and young adults with SM or anxiety to read this book. It's a really well done book. And then the other ones are some of the ones that I use in session with kiddos. And I think we're pretty good on time. I've got some time for any questions. I love questions. Please ask them.
I had a question.
Yes.
So this is Michael Kruer. Wonderful talk, Alicia. Really
Oh,
really
thank you.
great topic material. I was curious. Just I understand the way that you presented SM. From the DSM standpoint. But in terms of the selective mutism as a primary diagnosis versus kind of a blended phenotype. How often do you see kids with SM that don't have autism spectrum? They don't have any type of communication disorder. They don't have any anxiety disorder.
Mhm.
They just have SM because in the studies, it looked like, the percentages were varied quite a bit, but it was far from 100%. So I was
Yeah.
just curious about that.
Yeah, thank you for the question, Michael. Really appreciate it. So there is a lot of overlap, particularly with social anxiety and generalized anxiety. So most of the time, I'm seeing presentations at least comorbid with that. As it relates to overlap with autism, I would say more times than not, I'm seeing not an overlap there. I'm seeing more, SM with social anxiety, SM with generalized anxiety. Not a lot of depression in the young kiddos. I'm seeing that more with teenagers or young adults who haven't been treated. Um, but yeah, as far as it presenting just by itself, I have had a few. And it's, oh man, it's so fun to watch kiddos just progress through treatment and do exceptionally well and exceedingly well. But they do tend to continue to need some type of support. But they do make some really great progress. I have some kids in mind right now that I know are just plain SM, and have done really fabulous. But yeah, I would say the majority have additional, at least some social anxiety or separation anxiety or other kinds of anxiety disorders. Good question. Yeah. Thanks
Alicia, that was fabulous. This is Kara Lewis. I have a question for you too.
Yes, please.
And first, my comment is I really like being able to recognize that if we give a name to it, it takes the power and the stigma away from it. If it has a name, I think sometimes that is really helpful. And I can think back to a lot of my patients that I was seeing, for example, for seizures, epilepsy, who it was third or fourth or fifth visit before they ever talked to me. Or during COVID, they talked to me for the first time on Zoom, and I'm like, oh my gosh, you talk completely. And we're so busy, we're dealing with the seizures that I'm not addressing this as much. But I guess the question is just making sure, how do we find out if that is sort of the most bothersome symptom, the MBS, if this is the thing that is interfering with their school? Because sometimes I think the parents minimize it, like, oh yeah, they just don't talk to you. They're not going to talk to you. They don't talk to parents. They don't talk to teachers. But I'm thinking how disabling this is, and maybe we should be more proactive at finding out how much this is holding them back.
Yeah, that's a really great question. And I don't know how to make things like widely available, but I'm happy to in regards to like there's a school speech questionnaire that's literally like 6 questions for a teacher to fill out. And then the parent questionnaire that is just the SMQ. And it's actually been, there's been a lot of research on it as well amongst the SM community, but it's really just a list of 6 questions for them to ask their teacher. Because sometimes there isn't that communication, right? And the parents are kind of in the dark too. And I think that teachers, there's maybe a little bit of pride. I come from the school system too as a school psychologist, so I understand that piece as well. And I think sometimes there's that like, no, they're doing fine. Like I'm doing everything I can. And so there's not necessarily that communication. I highly encourage parents, like sit down with the teacher, find out what's going on, ask them who they're talking to at school, ask the kiddos, ask the teachers, and target like observation on what does lunchtime look like, because oftentimes these kiddos aren't eating lunch. They're coming home with full lunches because they have anxiety about eating in front of others, opening their mouth, chewing, things like that in front of other people too. And so that can be, a sign or a symptom that it's not going great. Also, what does recess look like? Are they by themselves? Are they talking to anybody? Because those unstructured times are like really telling for how a kiddo is actually functioning in the schools. And, I've done trainings for teachers, for administrators. And I think one of the things that is super important that they recognize is that, with needing specialized instruction or needing, something more at school, it's not just based on educational achievement, because a lot of these kiddos with anxiety are stellar students. They're gifted, they're getting straight A's. It's not impacting them from an academic standpoint, but we know there are some case studies and some court findings and things that relate to educational performance as it's defined in IDEA, which is the special education law, that says it's not just academic performance, social performance, communication, all of that is included when we talk about educational performance. So I think it's about broadening that understanding of what is it to be successful at school. And at the very minimum, some of the questions you can ask is, what happens if Johnny gets hurt at school? Are they talking to the teacher? Are they telling the nurse that they're hurt? Because these kids sometimes are getting picked on, they're getting pinched or bullied, and because other kids start to know, they're not going to say anything. And so there needs to be that communication with parents about how important it is that they're able to communicate. Yeah. Thank you. Good question. I hope that answered your question, Carolyn.
Yes, thank you.
Okay, and it was long-winded. Sorry about that.
I had another question actually as a follow-up.
Yeah.
This is Michael again.
Yeah.
So you mentioned the school setting, and I guess what's your experience in terms of the knowledge from the standpoint of school personnel? Is this a diagnosis that they're aware of, comfortable with? Is this something that speech and language pathologists are recognizing widely, or is there more need for recognition educationally as well?
Yeah, thank you for the question. Very limited knowledge, unless they've had a kiddo with SM and they've been educated. A lot of times parents, I tell parents that they are the liaison, right? They're the ones educating the teams. And, I've gone to schools and presented, and I will continue. I love this work, just informing people, but I would say it's fairly limited. I do think it's getting better. There was some time ago where speech pathologists were hands off on treating or touching it, because they said, it's not a communication disorder, it's an anxiety disorder, so we're not going to treat it. It's gotten a lot better. I did speak at ASHA, the Arizona Speech and Hearing Association, a few years ago, and was so happy to speak to so many speech pathologists about their role and how they can be helpful. And I think I'm seeing a lot more of a team approach. And speech pathologists, they have such great skills to help these kids. And so really them being able to step up. And I am seeing more of that, but I would say in general, it's fairly limited, and it's parents that are seeking help once they realize their kiddos aren't talking in school. And then it's just a lot of education, but we're working on it. I'm working on it.
This is Dana Raz in developmental pediatrics. I said thank you in the chat, but thank you so much for this wonderful presentation. It's so insightful, and it is such a highly, I think, misunderstood diagnosis. So I really appreciate you coming and speaking to us about it, and really great presentation.
Absolutely. Thank you so much. I appreciate the feedback. Thank you. Thanks for everyone who joined this morning so early. I appreciate all of you. And if you ever have any questions, please reach out. No question is minimal or please, I'm here to help. I want to be a resource for you guys. And so, I love consulting. I love talking about